Assalamu alaikum. Today's topic is non-alcoholic fatty liver disease, prepared by Dr. Angie Yusri Ashur, Professor of Gastroenterology and Hepatology. By the end of this lecture, you should be able to identify the risk factors for fatty liver disease, order the appropriate screening tests, diagnose and treat fatty liver disease, and initiate appropriate referrals. Non-alcoholic fatty liver disease, or Nafld, is a clinico-pathologic syndrome that represents a spectrum of liver disease encompassing simple fatty infiltration, or Nafld, or steatosis, fat and inflammation, or non-alcoholic steatohepatitis, which is NASH, and cirrhosis. All this should be found in the absence of significant alcohol intake and other common causes of steatosis. Significant alcohol consumption is typically a threshold of less than 20 grams per day for women and less than 30 grams per day for men. We have to differentiate between Nafld and NASH. As we said, Nafld is non-alcoholic fatty liver disease, which means steatosis or fat deposition in the liver cells without hepatocyte injury, while NASH, or non-alcoholic steatohepatitis, which encompasses hepatitis, is steatosis, that is fat deposition in the liver, associated with or causing inflammation, hepatocyte injury, with or without fibrosis. While non-alcoholic fatty liver disease is one of the most common chronic liver disease in the US, it comprises the fourth most common reason for liver transplantation, and it is projected to be the most common in the next 10 to 20 years. Up to 20 to 40% of adults, while 6 million children are affected. Well, non-alcoholic fatty liver disease is strongly associated with obesity, type 2 diabetes mellitus, with insulin resistance, dyslipidemia, and metabolic syndrome. In a large European study, it was found that Nafld is present in 94% of obese patients with body mass index more than 30 grams per meter squared, with a lesser percentage in the overweight patients and about 25% of normal weight patients. The overall prevalence of Nafld in patients with type 2 diabetes ranges from 40% to 70%. Other risk factors are the middle age, female gender, viral hepatitis, iron overload, some medications, mind you, rapid weight loss, starvation refeeding syndrome, malnutrition, total parenteral nutrition, acute fatty liver of pregnancy, and HELLP syndrome. The proposed histologic spectrum of Nafld begins with Stage 1, or fat deposition or fat infiltration of the liver cells. Then Stage 2, fat deposition is associated with inflammation, and then fat deposition with inflammation causes ballooning degeneration of hepatocytes, and this is NASH. Then this may cause fibrosis with or without Mallory bodies, and this is Stage 4. So, the natural history of fatty liver disease starts with a fatty liver due to deposition of fat in the liver cells, then necroinflammation causing steatohepatitis, then development of fibrosis, and then cirrhosis on top of fibrosis, which is a good percentage of cryptogenic cirrhosis. In these images, we can see how does the normal liver look and how fatty deposition in more than 5% of the liver cells called steatosis, and then how it progresses, the picture of the inflammation and development of the fibrosis, steatohepatitis, which then may progress to liver cirrhosis. Do all patients with non-alcoholic fatty liver disease develop cirrhosis or develop even complications of cirrhosis? We can see that simple steatosis or fat deposition of more than 5% could have a benign course, or in 3% they could develop cirrhosis. NASH could happen with ballooning and inflammation, as we said, plus or minus fibrosis. This, of course, encompasses a worse prognosis, as 30% develop cirrhosis. If severe NASH with fibrosis occurs, 75% will go into cirrhosis. With a 5-year survival of 67% in those with severe NASH with fibrosis and 10-year survival in 45% if cirrhosis occurs. How does non-alcoholic fatty liver disease present? Well, mostly it is an asymptomatic disease. Patients may complain of anorexia, nausea, malaise, fatigue, right upper quadrant discomfort, or the manifestations of metabolic syndrome as acanthosis nigricans, sleep apnea, or snoring. But the majority are asymptomatic, and they are found when they do some investigations or checkup, and liver functions are found to be elevated. On physical examination, there is abdominal obesity, an enlarged liver with right upper quadrant tendency. Although there are laboratory abnormalities, yet none of the currently used tests are specific for the diagnosis of Nafld. So Nafld is a diagnosis of exclusion. We can find liver enzymes either normal or mildly elevated, maybe 2 to 4-fold, AST-ALT ratio of less than 1. But if we find this is reversed, this suggests that cirrhosis has developed. Liver enzymes do not correlate with the severity of steatosis or fibrosis. Other laboratory abnormalities can be seen after cirrhosis develops in the form of hyperbilirubinemia, hypoalbuminemia, and abnormal prothrombin time. These are due to the complication. Hyperglycemia, hypertriglyceridemia, hypercholesterolemia, which are related to the metabolic syndrome. Elevation of serum ferritin, 20 to 50%, indicates liver fibrosis, not iron overload. The presence of hyperuricemia is associated with cirrhosis-related deaths or hospitalizations. Alkaline phosphatase and gamma-GT might be increased in advanced disease and might indicate increased mortality. Autoantibodies might be present at low titers, especially in advanced disease. But as we said, all of these are non-specific. What about imaging studies? Well, ultrasonography, which is safe, easy to perform, and acceptable, is the first line of imaging, as it shows a hyperechogenic liver. It appears whitish in the ultrasound, the hyperechogenic liver parenchyma, in contrast to the kidney or the spleen. But ultrasound cannot differentiate steatosis from fibrosis. Well, liver biopsy remains the gold standard investigation for diagnosis and assessment of degree of inflammation and extent of liver fibrosis, because this is important. We want to differentiate Nafld from NASH, from cirrhosis. It is not necessary in a typical patient, yet it is indicated in high ferritin, in positive autoantibodies, of course to exclude other causes of chronic liver disease, and in the accurate staging of the disease in patients with several risk factors. But mind you, liver biopsy has limitations as it is an invasive procedure with a risk of complications. Of course, there is also the risk of sampling error, taking the biopsy from a part of the liver not representing the disease, and inter-observer variability as well. It is important to start treatment early because we don't want patients with Nafld to develop NASH, as there is increased morbidity and mortality with NASH, as you all know. Therefore, lifestyle modification is very important, with weight loss by lower caloric intake and increased physical exercise. 9.3% weight loss causes improvement in steatosis, necrosis, and inflammation, but not fibrosis, while 3 to 5% of weight loss improves steatosis, but more is needed to improve inflammation. Besides lifestyle modification, we have potential pharmacologic treatment options for Nafld related, to the findings of the metabolic syndrome, as for example, to treat insulin resistance, we have insulin sensitizing agents. We have for dyslipidemia, lipid lowering agents, and antioxidants as vitamin E, vitamin C, and others. Membrane stabilizing agents, and there are future potential treatments as well. Insulin sensitizing agents as metformin, which cause reduction in the insulin resistance and enzymes, but there is no improvement in histology, while thiazolidinediones cause improved enzymes and steatosis, but not inflammation. Pioglitazone causes weight gain, but there is improvement in hepatocellular injury. As regards vitamin E, at 100 international units per day, this improves liver histology in NASH patients. Ursodeoxycholic acid has no histologic benefit. Statins significantly improve liver biochemistries and cardiovascular outcomes in patients with elevated enzymes, likely due to NASH. And there is the possibility of bariatric surgery as well. To review the management algorithm, if we have a probable Nafld, we should give a trial of weight reduction, exercise, dietary changes, improved lipid or diabetic control, complete cessation of alcohol, and discontinuing all potential hepatotoxic drugs. If the liver function tests improve, then we continue follow-up and observation. If liver function tests still are elevated, we have to perform a liver biopsy, and if it confirms that we are still in the stage of steatosis only, then we can continue the above mentioned lifestyle modifications with lipid and diabetic control, and of course discontinuing all potential hepatotoxic drugs or alcohol. What if there is, by biopsy, there is confirmed NASH? At this stage, we should consider antioxidant therapy and entry into clinical drug trial. If liver biopsy shows cirrhosis, we have to refer to a hepatologist. Please prepare your questions for the face-to-face session. Thank you.